Ladies and gentlemen, buenas tardes, good evening. Thank you very much for attending this very last session prior to the General Assembly. I thought a good complement to the more general introduction of Catherine Payne is to look at one case study, and that's what I intend to do in the next 40 minutes, to look at the case study of Lynch syndrome screening. So we'll start once again with a brief introduction. What do we mean by cost effectiveness and the methodological issues involved there? I then want to illustrate those issues which are also of particular relevance for genetic testing in this case study of Lynch syndrome screening. Then want to give a brief overview on cost effectiveness of other areas of genetic testing, and finally conclude with some summarizing remarks. Typically, health economists talk about ICERs, incremental cost effectiveness ratios, at least when they are doing health economic evaluation. And as Catherine Payne said, that's not the only thing we are doing, but quite sometimes we do. What is an ICER? The first thing you look at when you assess a new medical intervention, like a new diagnostic test, new screening strategy, is that you ask, you have some standard care and you have new interventions, and you want to know, is it more or less effective? Are there better health outcomes for this new intervention? Health economic evaluation adds a second perspective to this and also looks at what are the additional costs incurred with this new intervention. And then when you look at this, there are two, in this cost effectiveness plane, there are two quadrants where the conclusion is quite straightforward. First, an intervention could incur higher cost here and lower effect. Of course, you would reject such a technology. That type of technology is called dominated technology. Also, it could incur lower cost and it could be more effective. And of course, those are the no-brainers, the cases we want to have in our healthcare system as much as possible. Those are called dominant alternatives. In theory, you could also look at technologies where you can save a bit of money but also have somewhat less health gain. But in all my health economic life so far, I have never come across any health economic evaluation which looked at this case. But typically, all health economic evaluation look at new interventions which cost more but which also provide more health gain. And this is where you do health economic evaluation and look at incremental cost effectiveness. Now looking at those four cases, the alternative D is marked red, and having listened carefully to what I said before, it's quite clear why this is the case. The technology D is dominated by technology A, which costs less and provides more health gain, so therefore technology D will be excluded from the further analysis, which is quite relevant for genetics because typically there are very many different ways how genetic tests could be used or how different tests could be put in a sequence. Typically, you have very many different testing strategies which you could use, and when you do a health economic evaluation, most of those different testing strategies are dominated or are subject to something which you can see here under C, the so-called extended dominance. It's not directly dominated by technology EMA, but it is dominated by a combination. So if you give to some patients standard care and to some other patients technology A, then this blend of this mixture of technology, this dominates technology C. So that's what we would call extended dominance. So then what remains is the two technologies on the efficiency frontier, technologies A and B. And for this, you calculate the incremental cost effectiveness ratio. Now assume technology A provides 2 additional life years. So you have 2 life years gained, and it costs additional 50,000 euros. What you would calculate is the incremental cost divided by the incremental life years gained, which in this case would be 25,000 euros. Now it's very important always to look at the incremental, at the additional costs and the additional effects. So therefore, when you do the cost effectiveness analysis of the option B here, you would not divide the 2.1 life year gained or the 70,000 euros by the 2.1 life years gained, but you would look at the increment. So you look at the additional cost, which is 70,000 minus 50,000, and the additional health effects, which is 2.1 minus 2. So you arrive at 200,000 euros per life year gained. By the way, I just saw someone taking a picture of the slide. The slides are going to be available somewhere. I was asked before whether I'm happy to share them, and I told Same is the case with Catherine Payne. So I don't know how it works with sharing the slides, but you can have them. Now, in this special case, technology B has an incremental cost-effectiveness ratio of 200,000 euros per life year gained. Whether or not this is considered cost-effective, that's not for the health economists to decide, but it's a political question. But still, it's a very interesting question where also there's a lot of economic and ethical debate about reasonable benchmarks for estimating cost-effectiveness. That's one of my favorite topics, so I could talk for hours just about this question of can there be a threshold, what could this threshold be, what are the limitations of this, but unfortunately I can't really talk in this session about all those details, but instead I will focus on the question on how do we calculate those figures. And if we want to calculate those figures, of course there are we run into a number of methodological issues we have to observe, and just in case you come across either health economic evaluations as part of a guideline committee where you want to consider economic evidence, or maybe if you are working on a health economic evaluation yourself, maybe you want to do an analysis for products you offer or which are used in your laboratory, I strongly recommend looking at this paper here of Husserl and colleagues, the CHEERS statement, the Consolidated Health Economic Evaluation Reporting Standards, which provide an overview of important things to keep in mind. It has been published in BMJ, but also in a number of other journals, and it's sort of a reference case of what a good health economic evaluation is and what details should be reported in there. So it's good to have this in mind. There's a long list of many items. I just picked out 7 of them, which are also of particular relevance for genetic testing. So first it is important to describe the target population properly, and this is of high importance because depending on whom you offer a test, the probability to identify carriers or affected individuals differs a lot. And in consequence, also the effectiveness and cost effectiveness has an important impact on the cost effectiveness of testing. And actually, genetic tests can be used simply for the purpose of defining a target population. If you have pharmacogenetic tests which are only effective in high-risk individuals or which are more effective in high-risk individuals. So first, describe the target population properly, and second point, having the relevant comparators in the study. And as we saw on the previous slide, including the comparator A in the analysis turned the cost effectiveness from, we had here those 70,000 divided by 2.1, which is roughly 33,000 euros per life year gained, including comparator A, turned the cost effectiveness of comparator B from 32,000 to 200,000 euros per life year gained. So it's important to have all the relevant comparators inside. Third, you have the question of the choice of outcomes, and there are all those basic questions of what do we evaluate, what is our basic guiding principle for the economic evaluation, something which Catherine already touched on. Fourth, you have to look at the costs, and it's important to identify them, measure them, and value them in a transparent manner. Fifth, the choice of analytic approach. There are many ways of how you could calculate, do those numbers, get those numbers of costs and effects. Could be by means of models, could be different approaches. So you need to be transparent about this and justify your choice of analytic approach. Sixth, once you have done your analysis or when you do a decision analytic model, once you have your model structure, you need to have the best available evidence about the different parameters within this model, and you need to be transparent in how, for example, you chose the effectiveness parameter for your presumed screening program. And seventh, there needs to be appropriate accounting for uncertainty, which is always present in health economic evaluation. So now I would like to go through those 7 items at one example, and to make my life a bit easier, I took one case study where I'm among the co-authors of the study at an economic evaluation of screening for Lynch syndrome in Germany. The first point was the question with the target population, and there is also an issue of spillover effects. Frequently you have different target populations in genetic testing. So first there is the index patient, there are the cancer patients, where you could have high-risk patients, and second, actually whom you want to reach, those are the family members. It could be first degree or also second degree relatives. Because what you do in Lynch syndrome screening, you start, at least in the approach we assessed here, you can start with colon cancer patients, could potentially among those colon cancer patients select high-risk individuals among them. Then you could do a lab analysis of the tumor tissue. If positive, you can do a germline mutation test. And finally, what you ultimately want to do is to detect a causative mutation and search for this mutation among first-degree relatives to help them undergo increased prevention and prevent their Lynch-associated increased tumor. So this was the issue of target population. Second, comparators. Typically, I also said in the beginning, there are very many comparators when you assess diagnostic testing strategies. In the case of Lynch syndrome screening, there is first thing you can do is that you have the Amsterdam or the revised Bethesda as clinical criteria for selecting high-risk people. Second, you can do tumor tissue testing by means of different methods, microsatellite instability testing, immunohistochemistry, or BRAF testing. And third, there are different ways how you could do the germline genetic testing. You could either sequence all mismatch repair genes, or if you've done IHC before, you could only sequence those where you can expect that there is a defective gene. And if you combine those strategies, you arrive at a huge number of different comparators you have in your study. And actually, there were so many comparators in our model that there were only 2 computers in my institute who could run this cost-effectiveness model simply because it used up so much space in the computer. So what you could do is first you could do the immunohistochemistry. If it's positive, then do germline genetic testing for all genes. Second, you could do the IHC, and if it's positive, and if MLH1 is missing, then you could do the BRAF testing to exclude sporadic tumors, and if this is positive and negative, only then do DNA testing. Third, you could do the IHC. If it's positive, do a microsatellite instability testing in addition, and only if this is positive, then do the DNA test. So you're more restrictive and just select the more high-risk cases. The alternative path could be to start with IHC. If it's positive, then do the DNA testing. And if it's negative, then do the MSI testing and only stop further DNA testing if also the MSI is negative. So there you would be more inclusive for to get as many mutations as possible. Fifth, you could start with MSI. If it's positive, do IHC testing, and if it's positive, do DNA testing in the appropriate sequence. And if it's negative, then test all MMR genes. You could sixth do MSI, and if it's positive, at once test for all MMR genes. Or finally, you could also offer a DNA test to all of the patients. And this could be combined with different family criteria, so you could either use Amsterdam or revised Bethesda, so you arrive at 21 comparators, including the do-nothing alternative, so really a lot to do for the computer. The next step is the question of what are the relevant outcomes if I want to create determined value. And the first option, which is sort of the standard in economics. Typically, health economists, or typically generally, economists think about value in terms of willingness to pay. So the question of what is worth something, they would say, well, let's be sort of democratic and ask the people what they are willing to give up from their scarce private budgets. And this is the best indicator of how important a certain service is. So you could ask people, what are you willing to pay for a certain genetic test, which has the big advantage that it's notoriously difficult to capture the benefits of genetic tests. And if you simply ask people, what are you willing to pay, just as if, how much are you willing to pay for a new smartphone, then you have all those different aspects which could play a role in this decision, and they are captured in your measure of value. But it has the big disadvantage. Consider we would do in Germany a willingness to pay study and ask how much are you willing to pay for a screening program for cystic fibrosis, or how much are you willing to pay for beta thalassemia? I would expect that the willingness to pay coming out of this study for cystic fibrosis is higher than for beta thalassemia. And I would expect that this has nothing to do with the seriousness of the condition, but simply because the white people in Germany who are more likely to be affected by cystic fibrosis, they simply have deeper pockets, and so they have a higher ability to pay, and due to this higher ability to pay, they would be willing more to pay. And most of you, I would assume, feel this is somehow unfair, if that should be the criterion to allocate scarce healthcare resources. There's something else which should guide decisions in this important aspect. There's also another thing that economists tend to believe that people are rational and that they can really evaluate all the different options. Now think we have, in this case, 22 different tests which differ only to a very small extent, and generally humans are very bad at dealing with small probabilities. So it's difficult to imagine anyhow what is an increase of 0.1% risk, what does this mean for me in my life? So one could doubt that humans really have the mental capacity to understand and to appropriately weight all those different aspects. So there are good reasons for economists to look in a very democratic manner on the issue of value, but on the other hand, there are also good reasons not to follow this path in health economics. And that's the reason why Catherine Penn said that hardly any health economist does do cost-benefit analysis, and that's also my experience. So we use other ways of valuing health. And the standard UK approach is to do cost-utility analysis, and this is also sort of the base case for health economists. That's how we would capture the value derived from healthcare. So it has to do something with the aim of healthcare is to produce health, and we have scarce resources. So an intervention is valuable if you gain more health from this specific use of scarce resources than from the alternative use, which is foregone, which could not be done because your technology was chosen. So you have the quality adjusted health gain. You would look at the net health benefit, so you compare the health you gain from this use of scarce resources with the health you could have gained elsewhere. So, which has the advantage, it captures a central aim of healthcare. Somehow it is about producing health or about making people healthy. On the other hand, there are many aspects which can be criticized regarding this approach. One is very fundamental. For us as Germans, we are much more deontological than the British. The British always want to maximize their utilitarians. We would say healthcare resource allocation is not about maximizing anything, but it's about fairness, about applying fair procedures, about accounting for human dignity. And this is not done by maximizing qualities, but by having somehow the decisions stick to reasonable rules, or however you could define this. So again, we are somewhere close to my favorite research topic, but there are also less fundamental issues, like if in the standard quality measures also fear is included. So in the EQ5D, one dimension is, are you anxious? Now if we do this Lynch syndrome testing and we account for the fact that all those who are informed about the fact that they might have Lynch syndrome, the first thing they experience is, oh, I might have hereditary cancer. So if we account for this fear in all those analyses, we might come to somewhat awkward results where you could say, well, actually it's about saving lives. And in cancer, it's quite straightforward. We're talking about very serious issues, so we might not need all those subtle other things, but let's take the standard measure, which is also the measure when we talk about new drugs. So a third option would be cost-effectiveness analysis. You could calculate any medical outcome. You could also calculate life years gained. It has the assumption that somehow the decision maker will make this valuation, and somehow the decision maker is right by making this evaluation. It has the advantage that you are closest to clinical considerations. So you measure any kind of health output, and that's what also the clinicians look at. On the other hand, you have the disadvantage that it's typically inconsistent. You have no idea what goes on in the minds of the decision makers. They value different endpoints, potentially inconsistently. In this case, that was the approach we chose. We looked at the cost per life year gained, also because to make our lives simpler, because it's easier to calculate life years gained than to calculate further aspects, and to make good choices about how to incorporate fears potentially induced by testing. So this was the point of there should be a choice of relevant outcomes, a justified choice. Then the next point is to identify, measure, and value resource consumption. And it's important when we talk about costs. There's the issue of perspective, which was touched by Catherine Payne. When we talk about costs, it's always costs to whom, and the cost to a healthcare provider can be completely different from the cost for a healthcare system, and this can still be different from the cost from a societal perspective, because the healthcare provider has to pay his or her employees. The healthcare system just pays the reimbursement rates, which can differ, and from a societal perspective, it might be that there are cost savings in other sectors which are not factored into an analysis just focusing on the healthcare sector. In any case, what is important about the cost effectiveness of genetic tests is that the first thing you think of when you talk about the cost effectiveness of genetic testing is the decreasing cost per mutation tested. Of course, those costs are falling tremendously, but still sequencing is just one part of the cost. You also have other lab tests which may play a role. You have the cost of counseling, and actually even if the cost per mutation are falling, it could be that counseling gets more and more expensive simply because there is more and more genetic knowledge which has to be conveyed to the patient. So therefore, the fact that the cost per mutation is falling does not at all mean that the cost of genetic testing is falling if we look at it properly. And you have, counseling and the matter of interpretation. But that's just the testing costs in the healthcare system. In the slide of Catherine Payne, you saw this, the different aspects of the care process. In the case of Lynch syndrome testing, there would be the costs of prevention. We modeled also aspirin prevention. That's one aspect. We have colonoscopy. And if you look at colonoscopy, you also have to look at polypectomy and potentially histology that comes after detecting affected polyps. And on the other hand, potential complications from colonoscopy, like perforation of the bowels. And then finally, you have the treatment costs. In this case, the economic impact was that you could avoid treatment costs. You have avoided cancers. We just used aggregated mean treatment costs depending on the cancer stage. So we found a cost study which had this in it. Soon as one member or one patient got cancer, we could simply take those average costs. Quite frequently for genetic testing, those costs are not negative, like here, that they induce savings, but they are positive, and you have potentially very expensive medications and expensive treatments that follow subsequent to a genetic test. Now we know what the endpoint is, we know what costs we are talking about. Now is the question, how do we measure this cost and effect and their increment? And as Catherine Payne already pointed out, there are different ways. She mentioned two ways. I would mention three different general approaches of what you could do. The first is so-called piggyback health economic evaluation, which are just an add-on to a clinical trial. So you have your clinical trial, you assess your trial endpoints, and in addition, you could have cost questionnaires so that you also calculate the cost or ask the patients for the costs they are incurring in their situation, which has all the big advantages of the clinical trials, the high internal validity, and that you really know what is going on, that you have very thorough documentation, well reflected, but you also have all the limitations of clinical trials, which is that you have an awfully short time horizon because no one can afford a trial for a lifetime horizon. But especially for predictive genetic testing, we're interested in endpoints which will occur much, much later, far beyond the time horizon of any clinical trial. Second, clinical trials are awfully expensive. And if you imagine all the different testing options we have, it would be impossible to fund clinical trials for all of those new testing options. And third, your results are only valid for the clinical trial setting, and this is typically quite artificial. And what you're eventually interested in is the costs and effects in clinical practice. So to look at clinical practice, a second approach, and that's also something we have done in our institute, is to assess the treatment, the costs of a treatment and control group in routine data, like you take data of a sickness fund and you identify individuals with a treatment and without this treatment and try to compare the costs and effects of those two groups, which is a nice thing to do. It has all the advantages of the analysis of routine data. You're looking at routine care, but it also has all the disadvantages of observational data with all the biases which are involved there. And one specific issue about genetic testing, you have a lack of medical or diagnostic information. So we wanted to do such an analysis for another area, UGT1A1 genetic testing. And we proposed this to a sickness fund, and we went a bit further with our analysis. And the key point was we can see in our data whether a doctor did the diagnostic test, but we do not see the test outcome. And so we see what happens afterwards, but we don't even know whether maybe the doctor has prescribed the medication even despite a negative test result or whatever. So this can only be done if you have a good proxy for the medical endpoints. And the third point, the approach we chose in our study, and which is sort of standard, and it's the most frequently, the approach I have seen most frequently for genetic testing, is to use decision analytic models, where you integrate the best available evidence into some mathematical model, where you represent the disease and its pathway, and the effect of the treatment on the disease pathway, and then you calculate the costs and effects for the different groups, which is a nice thing to do. You have lifetime horizon. You can collect the data exactly for your decision problem. You do not have to restrict yourself to the short time horizon available from a clinical trial or what you can see in your observational data. But of course, also models have a number of limitations. One, I think, is one of the strongest limitations is that it's awfully tempting when you are working on a model to look what is going to come out if I change this parameter, if I change that parameter. And it's so tempting to create the model and to build the model to fit your desired outcomes rather than just to build the model and see what comes out. And in the end, the healthcare decision makers, frequently they have the impression, I can't really understand the model. There's someone who has a complex mathematical thing and quickly talks me through it, and I have no clue where those little screws are, where the researcher might have worked on to make the result fit as he or she wished it to be. Nevertheless, I think it's one of the standard approaches and an approach we used here, so I would say it's a valid and reasonable approach to assess the question of cost effectiveness in genetic testing. Now, once we have decided to do a decision analytic model for our cost effectiveness analysis, there are different approaches how you could do such a decision analytic model. One thing is to have a decision tree. So you have a simple representation of chance events which helps structure a decision and get clarity about a care process, but it's not suitable for repeated events. It can easily get very complex if you have more complex pathways. A second way how you could address it is to do a Markov model. In a Markov model, a disease is represented not just as chance events, so either the patient gets the drug or he does not get it, may be infected, may not be infected, and then disease may be serious or not, so that would be a decision tree, but instead you have disjunct health states. So for example, if we model cancer, we have a state, well, you're healthy, then you may develop cancer stage 1, cancer stage 2, cancer stage 3, maybe cancer stage 4, and then there's an absorbing health state, which is death, unfortunately, in our life, and you have those different disjunct health states, and the model assesses transition probabilities across those health states, and you have a number of cycles, and for each cycle you assess how many individuals pass over to the different health states, and in the end, after a lifetime perspective, we all end up in the absorbing state of health, and then you can compare the health years gained or the costs accrued for the different groups, either with treatment or without treatment, which is sort of standard approach. which is rather easy to parameterize, but which has the difficulty that it's not suited for dynamic pathways. And that's one thing Catherine Payne also said, that frequently genetic tests are used to change clinical pathways. And depending on the test result, a new pathway is triggered, and it get awfully complex. And there, an alternative way would be to use this discrete event simulation, where disease and care is represented as discrete events, which occur in the course of a time. In this model, this type of model has memories of past events, and so can memorize what happened earlier, which is a nice and flexible instrument, which has the big disadvantage that it's awfully difficult to parameterize, because for a patient, after a sequence of diseases, then to say what is for this patient the probability of developing a different disease, it's typically the data are simply not there. It's easier for a Markov model where you have those disjunct health states which are well described in epidemiological studies, and where you know the probability of someone in cancer stage 2 to develop cancer stage 3. In our study, we combined a decision tree to analyze the testing process with a Markov model to analyze the effects and costs of the prevention part. So the decision tree we had in the beginning, like you had the first strategy which started with immunohistochemistry and then DNA testing for those where IHC was positive. Eventually, you have to look at all the different steps before. So you have the first thing is that you approach the patient, you're doing a genetic test, so you should first offer counseling to him, and the patient may refuse counseling, but still he may or she may also uptake counseling. Then after counseling, the patient may decide not to undergo the test or to do the test. And once we have done the test, it could actually be that this patient is negative, but still all the other tests are true positive, and you can come up to a situation where you send first-degree relatives to a prevention program, even if there has never ever been a mutation there. But now let's assume the patient is a carrier, then there is still a risk that the test you have done is false negative. So you have had all those costs before, but then in the end, no one is detected among the family members because it was false negative. It could have been true positive, and then there could be different outcomes. Then still you could find a mutation or not find it, and then it continues to first-degree relatives. And in the end, you have first-degree relatives which are either detected or undetected, and who either have the mutation or don't have the mutation. So this is the first part of the model. And the second part is a Markov model where we looked at the disease in terms of different disease stages. So the first-degree relatives, first they are well, and they can stay in this well state. This is signified by this arrow. And they can just die a healthy death, sort of, just a natural death of whatever. And in the end, so death is the absorbing health state. In the end of the model, everyone will be in this death state earlier or later. Or, of course, as they have Lynch syndrome, they may develop cancer. And they may develop cancer, and when the cancer is detected, it can be in the stages 1, 2, 3, or 4. And depending on whether they are on increased colonoscopy or not, the stage distribution is different. And depending on the stage distribution, the mortality from cancer differs. They can also remain in the cancer state, and after 10 years, they can reach the state of well after cancer. Also, as we are in Lynch syndrome, there can be metachronous cancers, so patients can develop second cancer, and again, the stage distribution depends on or differs by either if they have increased colonoscopy or not, and also the incidence of cancer depends on whether or not they're on colonoscopy, because cancer could also be prevented by polypectomy before the cancer gets into being. So now you have a model with a decision tree, and in the end, all the people enter into this Markov model. It's quite clear you need many parameters to get figures out of this model structure, and these things include you need knowledge about the uptake of the index patients, of the relatives, which is very difficult and a crucial point. All the health benefit depend on whether or not the patients do the testing, and whether the first-degree relatives are indeed contacted and whether they undergo testing. So it's a crucial parameter, even if it's typically somewhat disregarded in the epidemiological literature. You have the sensitivity and specificity for the different tests. You have the prevalences of the Lynch syndrome and of the different genes. You have information on the population, like the number and age distribution of the relatives, because also the age has an impact on cancer mortality and incidence. You have the cancer risk, which depends on age and on mutation status. So you need information on to what extent it depends on the mutation status. You have the effects of the prevention, so the different stage distribution or the reduced incidence by increased colonoscopy. And finally, you have the cost of all those different aspects in the model, of the different steps on the first side of the model, and so the testing part, and second in the prevention part. So there's a lot I could tell about those parameters. If you have questions, I have many backup slides with details about all of these. I will instead go to the results. First, the results of the Markov model, and what you can see here. So here we compared for individuals with standard prevention, and standard prevention means for Germany they will be offered colonoscopy at the age of 55 with a fairly low uptake. So just like for the general population. And in this case, the patient or the mutation carriers have rather high costs of colorectal cancer. They have rather low cost of colonoscopic prevention. They have zero cost of aspirin prevention in total. So everyone incurs costs in the end. So they incur cost of roughly 5,000 euros. Then you have the other group where they have increased prevention, which has as consequence you have lower cost of cancers because you have many cancers which are avoided. On the other hand, you have higher cost of colonoscopic prevention, so you have savings in cancer of nearly 3,500 euros. You have add-on costs for prevention, for colonoscopy, and of course you have add-on costs for aspirin. So in total you have slightly higher costs for those who have undergone prevention, but it's not a problem, of course. I mean, we are in this area of the cost effectiveness plane where you have additional effects, but also additional costs. And you can see the life years gained differ a bit by whether it's men or women, but in total you have roughly an estimated health gain of half a life year if the mutation carriers undergo increased prevention compared with those who do not undergo increased prevention. So this was just the results for this Markov model, which compared the costs and effects of the patients. But we are interested in the cost effectiveness of the whole testing procedure. And as I said, there are 22 different alternatives. And this is just to show that far most of those alternatives are, we had this term before, are dominated. And this domination can be quite strongly here. If you compare this alternative to this alternative, you have, in this case, like 20 million euros you can save from a healthcare system perspective, and roughly 60 life years you can gain. So it makes a difference which alternative you choose, both for patients and for the healthcare system. Now looking just at the undominated alternatives, there are only 4 left. The first is do nothing, then the B2, where you start with Bethesda criteria and then do IHC, then BRAF, and then sequencing. The next would be this without the Bethesda criteria in front, and the last would be direct counseling and direct sequencing for all cancer patients. You see there's a huge jump in the effectiveness, in the costs, and only rather little add-on to the effects. If we look at the incremental cost effectiveness, you see no screening, of course, no increment. On the B2, you can have additional costs in a healthcare system perspective of 33 million euros. That's the cost of this screening program, but you gain most of the life years. You can gain 300 life years, also from a German perspective, at a cost of roughly 70,000 euros per life year gained. Then for the next expensive strategy, you gain another 41 life years at another cost of 10 million euros. which is already less favorable, of more than 250,000 euros per life you gain than if you choose for we sequence everyone at the current test cost. You can gain another 54 life years, but add another more than 200 million euros from a healthcare system perspective. So a last point, methodological point, was to make the decision model probabilistic. Like, for example, uptake is an uncertain parameter, and it's important to account for the joint parameter uncertainty, because in the Monte Carlo simulation, we would not do this analysis, as I just showed, as a deterministic analysis done one, but you have random draws from all your input distributions. So how to create those uptake has a value between 0 and 1. A candidate distribution in this case would be a beta distribution. We would look into a clinical study. We found a study of Schneider and colleagues where 23 out of 78 colleagues had undergone testing in a consortium of Lynch syndrome patients. So this can simply be used to assign a parameter distribution to this one parameter. And this is done for all the other parameters. As I said, all those details are in the backup slides. In the end, you do not only have the incremental cost effectiveness as one result, but you could also, for different potential willingness to pay, a probability of whether or not an intervention would be considered cost effective. Now I went through one example of genetic testing in cancer, and it's a somewhat frustrating example, or at least the cost effectiveness in our study was not very low, very favorable. There are also other examples. For example, we looked at UGT1A1 testing prior to administering irinotecan in patients with metastatic colorectal cancer, where individuals with this mutation have increased toxicity and can experience diarrhea, neutropenia. And here we analyzed 3 different options. First, to do nothing. Second, to do a genetic test and have a dose reduction in those who are positive, because they are slow metabolizers, therefore that's the reason for the higher toxicity. Or third, you could test and give growth factors to those who are positive. And here it's a different picture. The strategy 2, genetic testing plus dose reduction, is clearly dominating. So you have savings of about 580 euros per patient, plus gains in health-related quality of life. So this is one area where genetic testing could indeed not only improve patient health, but also save healthcare money. But it's uncertain. We would need something like coverage with evidence development to confirm those results. So, general, what would be your guess? Is genetic testing or genetically stratified medicine, is it more cost effective or is it least cost effective? If you think about it, have your own view, what would be your guess? We did a huge study on that, analyzed all the health economic evaluations dedicated at personalized medicine where genetic markers were used to stratify medicine. Have you made up your mind? We were really surprised about our finding, because the incremental cost effectiveness ratio of stratified compared to non-stratified medicine is just equal. It's the same 22,000 euros per dollar, which you would also have for any other type of care. On the other hand, what we also found was that there were many different alternatives, and among those there were quite frequently alternatives with very favorable ICERs, and nearly 50% where the testing strategy was even the targeted strategy was even a dominant one. On the other hand, there were on the most disfavorable, the unfavorable ICERs, nearly one quarter where the strategy was either dominated or above 100,000 euros per quality, so really expensive. So basically, when we talk about the cost effectiveness of genetic testing, it's not the question of whether you use genetic markers, but much more how and where in the care process they are used. Of course, there are many limitations also to this study. It's subject to high uncertainty. There's limited scope. There's a need for update. And actually, in case you're still in this room and still interested in this topic, we're currently working on a grant proposal to assess the cost effectiveness of Lynch syndrome screening across Europe. So you can drop me an email if you're interested in this area and would be prepared to be a partner of qualitative interviews to tell us about your experiences. But briefly to summarize my key messages. First, in case you come across economic evaluation, have a look at the standards. I would recommend you looking at the CRC standards to get an idea of what good evaluations are. Second, there are multiple drivers of cost effectiveness beyond the test characteristics. So it's not just the cost per mutation detected, but it's things like effectiveness of the treatment, uptake, and physician behavior, which also have to be taken into account. Third, cost effectiveness of genetic testing is not a matter of whether, but of how genetic tests are used, and economic evaluation can help target the use of genetic testing to the most cost-effective uses. Fourth, this case study, again, like Catherine Payne, demonstrated a number of challenges, like, for example, what is value and those spillover effects to first-degree relatives. And finally, resources are scarce, so I might be somewhat biased in this statement, but there are good reasons to include economics both in grant proposals and in guidelines development, but it should be done in an ethically reflected manner. So clearly we're not just maximizers of something, but it's just a bit of interesting information. Muchas gracias.